We're live.
Hello, friends, and very good evening to all of you. So, I welcome you on behalf of Mumbai ICCM. I'm Dr. Bharat Jagiasi. I'm Secretary of Indian Society of Critical Care Medicine, that is Mumbai branch, and it's very nice evening to have you all around on the weekend. So, the main purpose of this webcast, as the Mumbai branch keeps on doing the regular basis, so this is mainly the discussion on the treatment modalities in COVID-19. As we all know, there have been too many treatment. We started with the hydroxychloroquine, ivermectin, azithromycin, Zincovit, vitamin C, and now molnupiravir. Remdesivir is still on board. Monoclonal antibodies, we don't know what exactly the role is. Baricitinib, steroids to discuss it, tocilizumab. So there are too many things in the armatorium. So when he started with it, there was hardly anything around. We didn't know what exactly it is. But then now too many things, and we don't know how useful they are. So it's like we didn't have anything, and now we have many things, but still we don't know how effective and how useful they are, if at all they are useful, when they should be used, till how long the duration should be, what time they should be introduced to it. Because as we all know, majority of the infections are asymptomatic or mild in this duration, and they don't need anything apart from the symptomatic treatment. So I think it's bits of a confusion amongst all the treating physicians and the treating doctors, what to use, when to use, and especially what not to use. I think the most important message at this point of time, what we have to give is what not to use, because we've seen many things being around were used in the initial days, and now the clear science is there, those are not effective, but still people are being using it, maybe there's no update on it. So we thought we'll discuss all those at this moment, and finally give a final message to it. So I welcome all the delegates on behalf of Mumbai ICCM, and then now I'll welcome all my honorable speakers along with me. So I have Dr. Vinod Kumar Paul with me, and we are really honored to have sir on this platform. And it's really honor for me as a student to be chatting with him and talking to him. So sir is an, as we all know, a pediatrician, physician scientist, currently member of NITI AAYOG. He's chairing the National Task Force of COVID-19 and also a member of NAGVAC, that is chairman of NAGVAC, that is National Expert Group on Vaccine Administration for COVID-19. Sir, warm welcome to this webcast by Mumbai ICCM branch.
Thank you. Thank you
Thank
very
you.
much.
Yes, sir.
I look forward to hearing the discussions, and I may like to add a few important points toward the end. But very pleased to be here, and I know that the physician fraternity of Mumbai has risen to the occasion across the entire, duration, the span of the, the the challenging pandemic that we have faced, because Mumbai and Delhi, both two metropolitan cities in particular, have always had a very severe onslaught, first wave, second wave, and the third surge, and so on. But you have been, the city and the state of Maharashtra has been lucky to have stellar physicians with a scientific bent and deep clinical commitment and commitment to evidence-based practice, who you steer the clinical management, as well as, of course, support to pandemic response in a very rational way. Congratulate you all. And all I
Thank
want to say here is that the virus has not gone anywhere. We have a new phase of the virus that is now playing havoc in our country as also in the world. Uh, we still have a long way in continue to fight this virus, and hopefully someday we will be in a position to live with the virus when the virus will look at us innocuously. Thank you.
Thank you, sir. So it's really honor to have you on board, and thank you for those comments. It drives our passion towards the science, as you said. Now, I welcome Dr. Rahul Pandit. Everyone know Dr. Rahul Pandit, as he's been member of COVID Task Force Maharashtra State, and also as a Supreme Task Force. And we everyone across the nation knows him as well. And really honored to have you, sir, Director of Fortis Healthcare Critical Care Department. Well, I welcome you, sir. I mean, you've been with us and you've been mentoring us as well. It's really nice to have you on board, sir.
Thank you very much, Dr. Bharat. And first of all, thank you very much, Paul, sir. It's an honor to share the screen with you. Honestly, it is something which brings a lot of pride to be actually associated with you on a learning and a teaching platform, sir. Bharat, I think what you've said is absolutely right. There needs to be some rationalization of the treatment modalities and intensive care as a community. We are around 10,000, 12,000 members across the country with Indian Society of Critical Care Medicine. And all of us from Kashmir to Kanyakumari and from Mumbai to Kolkata, east, west, north, south, have actually contributed immensely to the whole ongoing pandemic fight in the intensive care units. And a lot of critical care patients across the country have been treated quite well. And I really feel honored that Sir has appreciated the Mumbai as well as the Maharashtra doctors. Thank you very much for that, sir. But I think most importantly, what has come out of this is that we actually have intensive care, which has now grown up as a specialty during this pandemic. And common man, the medical fraternity always appreciated intensive care. There was no doubt about that. But now even a common man understands what an intensive care does and what an intensivist is, and how we are been making a difference to the critical patients, which is very unfortunate because we don't want any critical patients in this whole pandemic to be there. But what can we do? There are some patients who require critical care, and that's where we step in. The good part about this third wave, which is going on right now in our country, is that not many of them are requiring critical care admission, which is the only thanking grace which God has given us in this third wave. But still, there are some who do require critical care, and we need to pick them up at the right time so that we can admit them and give them the right treatment. And again, it just brings back to that treatment word: what treatment, when to give, how long to give, and we make sure that we don't actually land up with complications of the treatment. Like for example, we had mucormycosis in the second wave, which was creating a lot of misunderstanding again, that why did it happen in the first place. So I think this is going to be a very good learning platform. Thank you very much, Bharat. Back to you.
Yeah, thank you, sir. Thanks for being with us and allowing us to have you on this board. And as you rightly said, sir, I mean, this pandemic, what it has done is, and we all are worried about the critical patients and critical care society all across the nation, especially the ICCM has played a good role in that. And we have seen the results, which are at par, and the amount of efforts have been put extremely appreciated all across the nation. Now, I have Dr. Akshay Kumar Chalani with me. Dr. Akshay Chalani is physician and intensivist in Navi Mumbai. Welcome, Dr. Akshay. Welcome on board.
Yeah, thank you, Dr. Bharat, and thank you, Dr. Rahul and Dr. Paul, sir. I am privileged to be with you on this platform. And as Dr. Rahul has already said, we'll be happy to treat the patients, but at the same time, we don't want any morbidity in the context of COVID, which we feel that potentially avoidable. And at the end of, I think, these sessions, as Dr. Bharat has rightly said, what we need to know, what not to do, when not to use this drug, because in the first wave, we were not very sure. But as the time goes up and as we become more mature, I think we have the grip of the situation and we are more wise now to treat the patients. So rightly said, we need to learn few things at the same time. We just need to de-learn few things. And thank you, Dr. Bharat.
Yeah, Dr. Akshay, I would say we have to turn and wiser as the time goes on, still not wise enough to know this virus and treat it. So we'll start with the panel discussion. Dr. Rahul, I'll come to you first. I mean, we all know we have the maximum Omicron cases all across the globe and especially in the India too. So what is your current take on this pandemic and what do you expect? What is coming in the future for us? Are we looking at the end of it, or you consider something is coming? I know no one has the answer, but what exactly your take, or because you've been listening to the scientists all across the globe and you've been in touch with the experts, so you're the better person to answer this.
Thank you very much, Bharat. So, look, since the time we started to hear this word Omicron, which was in the last week of November, when it first surfaced up in the medical literature, and we all identified that to be coming from Botswana and South Africa, that region around the southern end of the African continent, we saw that it had a very, very high transmissibility, almost to the extent that it is as transmissible as closely as it can get to the measles virus. We know that measles virus has got a very, very high transmissibility. And that's what it did. It rapidly spread. It rapidly spread to patients across the South Africa. And then within no time, it was prominently seen across the globe. What it did was another thing is that it replaced the existing predominant Delta strain. The Delta strain was very robust strain. People thought, all scientists thought it would be very difficult to replace Delta, but Omicron replaced Delta to a larger extent across the globe, and it became the predominant strain in the world. India, we started getting cases towards the middle or end of December, and Mumbai specifically cases started rising up in the month of December, around 20th of December or so. And very rapidly, in a span of less than 3 weeks, we reached almost 20,000 cases from 200 odd cases which we were there before. And that peak, fortunately, did not stay for a long time. And as it went up in South Africa and came down quite rapidly, as it went up in UK and stayed on and then came down quite rapidly, the similar trend was seen in Mumbai as well. However, as a country, we are a very huge country. Comparing the population of South Africa or UK would be like comparing a population of one of our states. And we will, as a country, obviously have different timelines in terms of when the cases would start going up and when they would come down. And we will have to just wait and see as a country for few more weeks before we can say that as a country we have peaked. While in clusters, Mumbai has definitely started to go down well and truly. Rest of the Maharashtra and rest of the country is still into various stages of this third wave, and we cannot say that the virus has gone away. The virus is pretty much there with us. Now, to predict where we are going to be ahead in the next few months, I think everybody likes to hear that word endemic. I would say that endemic is still a disease, and we should be looking at eradicating this to the point that we don't get troubled by it every day. While physiologically and from virological point of view, it may not be possible. We may probably be looking at an endemicity, but when it is going to come is very difficult. And there are two reasons for that. Because this virus has been absolutely predictably unpredictable. That's one reason. And secondly, until and unless we are able to vaccinate the entire population of the globe, we will not be able to, have a certain amount of confidence that newer strains would not come. And if the newer strains come, and where would it come from? Probably from the places where the vaccine penetration is not good. And how would it the characteristic of that strain be? It's very difficult to judge. So I think we should not be predicting. We should do things which are in our hand. And what is in our hand, and I'm sure everybody will agree, and Paul sir can give the comments in the end, is we should vaccinate everyone in this country and try and vaccinate everyone in the globe, across the globe, and adhere to the COVID appropriate behavior. I think these two things, if we do, no matter what strain comes, no matter how things go, we will learn to live with this virus slowly. And one fine day, it will go away. Whether it will go away in 2022 or 2023, nobody has a crystal ball. As doctors, we should not be speculative. We should be more practical of what we have as a problem in hand and see how we can deal with that.
Yeah, very rightly said, sir. I mean, we shouldn't be predicting it. We should take it as it comes in. We'll speak about the current situation as of now, what we are facing through. So, Dr. Akshay, as you've been a physician as well as intensive, so you are the right person to answer this because you've been seeing patients in the ward as well as in the critical area. So, what percentage of patients do you see in the wards and what percentage of patients do you see in the ICU? And if at all there are patients in the ICU, what exactly are the kind of those patients, those infected with Omicron?
Yeah, basically, suppose we compare this last year's Delta and this year's Omicron waves. Last time we see a lot of patients in the ICU actually, but this time we are seeing a lot of patients on the floor. What I mean to say, criticality or very sick patients generally in this Omicron are very less as compared to the Delta and Delta variants. And who are there in the ICU because Omicron per se, right now on the day 1, day 2, you don't know who are Omicron, who are Delta or Delta variant. But by and large, till moment, whatever we know little bit, still there are too much of morbidity, mortality in South Africa and USA because of Omicron per se. Daily we see death. But India, where I practice actually in NAVI, Mumbai, maximum number of patients as compared to the ICU, more on the floors, less in the ICU. And those who are in the ICU, either they are unvaccinated or along with the COVID, whether it is Omicron, they are with high comorbidities. Either it is malignancy, either it is immunocompromised, seropositive, or they are on diabetic, on long-term steroids. So coming to the answer to your questions, basically, hospitalization this wave, Omicron per se, is more on the floors, less in the ICU as compared to the Delta variant. And even if the ICU, those who are unvaccinated or partially vaccinated. This is the two different which I see in the hospitalization of this Omicron wave per se.
Can I add on
So
a few
what
things
I
to
was,
that, Bharat?
yeah, sir, I'll just come. I was coming to that question only. So what I was saying, it was coming to you. So what I was trying to clear my put my question more clearly. So supposedly, if I have to speak when the second wave had come in, so in a hospital we had around 80 bed of ICU, and we were ventilating 40 patients. So out of those 80, at least 76, 77 patients were, I mean, almost 95% patients were in ARDS. So this is what the pathophysiology was in ARDS. And as we peaked this time in Mumbai, we had in the peak we had 22 patients in ICU and just 4 patients with ARDS out of those 22. So majority of the patients are the different patients. Someone who had MI, stroke, pancreatitis, we had it, DK, diabetic ketoacidosis, and today we had just 12 patients and just 2 of them are ARDS. So in the initial, almost everyone was ARDS, and now very few ARDS. And Akshay rightly pointed out, those ARDS are with the high comorbidities or those are not vaccinated. So, sir, what is your take on this? I think you are going to answer this one.
No, I think you said it all. My only comment on that is that those who are on those who are having ARDS, again, this is an observation which I have got. I've spoken with a few doctors across the country as well. Those who are having ARDS, Bharat, they are having primary lung pathology. So
Thank you.
there is either a COPD, emphysema, something there in the lungs which they were already facing as a problem at home, which was not a normal thing, and they are the ones who are actually having the worst lung picture associated with whether it's Omicron or Delta. Now we know we are not genome sequencing everyone. The last genome sequencing report of Mumbai still showed around 10% Delta and Delta derivatives around 2-3%. So around 10 to 12% of Delta is still existing. But we certainly know now that the patients who are requiring high oxygen or oxygen support are those patients who are lungs were previously diseased and were not normal, or as Akshay said, they were unvaccinated. I haven't come across anybody in this wave in the ICU who is unvaccinated completely. So at least one dose they have received, or majority of them have received 2 doses. But as you rightly said, 85-90% of them were in the ICU because of an incidental COVID in them. We all are running a medical ICU or a surgical ICU with some COVID patients in it. That's the big difference between this wave and the first wave and the second wave.
Sir, as you rightly said, there are majority of the patients who have the comorbidities and with the pre-existing lung disease. But we have come across a patients like I have a 39-year-old boy, and we proved it's a Omicron with the S gene deletion, which was positive for him, and he just had a single vaccination. He took it, and he was a severe ARDS in category. Then I had in fact we are studying this. I mean, we are running a sequencing as well for few patients, and so there have been a patient, especially this one young boy. I mean, this was the only patient who was young, didn't have any comorbidities, and he landed up with the ARDS, and it was Omicron. But majority of the patient, as you rightly said, no, I just wanted to put across the board. There are few maybe which are coming across, but majority of them have some illnesses, and the only death we had was someone who was not vaccinated. It was Omicron, and ejection fraction was 10%, and he was case of MI. So that was the only that's what we had. So still we analyzing it, but most of the time it's only in the comorbidities, and as you rightly said, they had some underlying pathology. But wanted to put across, it's not true for everyone, so we need to have those preventive measures on for everyone. And so I'll move on to it, sir. I mean, we'll come to it as we discuss about the mix in the ICU patients and how many beds are being occupied, and we discuss it. So now when it comes to the treatment modalities, we'll come to our niche of the topic when it comes so in this era, I think we should be discussing treatment modalities for the OPD patients, because majority of the patients are on the OPD basis, and for the IPD patients and for the critical care patients. So, Dr. Akshay, again, I'll come to you for this. So, on what basis you decide this patient needs an IPD admission? And if it's an OPD admission, someone who's consulting you, what advice you give to those kind of patients?
Yeah, basically the treatment model is pretty forward and very clear cut actually. You don't require anything. Those patients on the OPD, no risk factor, young patients, other than paracetamol, you don't give anything. But if now coming back to the question, which patient you will hospitalize? If the fever is more than 3 days, patient has a persistent fever which is not responding to the paracetamol in spite of adequate dose, these patients I'll keep a low threshold to hospitalize the patient. And regarding the IPD, suppose fever is persistent but comorbidities, age is more than 60, uncontrolled sugar, high risk factor like malignancy or immunosuppressions or any chemotherapy, I'll keep low threshold to admit these patients. And subsequently, those who are tachypneic, respiratory distress, hypoxic, there is no doubt that this patient should hospitalize. But any young patient, I'll just wait at least 3 or 4 days for the fever to settle down. Not settling down, then I'll hospitalize them. And definitely, if there is a hypoxia, respiratory distress, or any organ dysfunction like creatinine is going haywire or liver enzymes are going haywire, then I'll hospitalize these patients.
So, Dr. Rahul, again, I'll come to you. Apart from those obvious organ dysfunction, what we can see, it could be kidney, liver, or the lungs, anything. I mean, what is the OPD advice you give when someone is consulted you on OPD basis, and when do you plan this patient needs an admission?
Sure. So, Bharat, I think one of the big responsibilities as doctors which we have right now is to actually identify the patients who would require to be admitted. And for that, we have now good tools available with us. So, simple advice, obviously, you need to tell them to measure the temperature 2 to 3 times in a day under the tongue, pulse oximetry at least 2 times in a day. One of the things which I ritually ask them to do is to do a 6-minute walk test morning and evening. And trust me, Bharat, we have got some publication going on with 6-minute walk test. 6-minute walk test actually help identify hypoxia very, very early and get these patients to the hospital in a timely fashion. Whichever patients have followed 6-minute walk test have required admission, they've required it for a very short span of time, and they have been discharged very quickly, whether it was a second wave or even in this wave. The other advice which I tell them is not to self-medicate. So most of them are given just supportive care. Supportive care in terms of paracetamol is the standard. If they have a blocked nose, we would use something for them. If they're runny nose, we might use cetirizine or something. But absolutely nothing in this wave. This wave has been less of medicines. No vitamins, no antibiotics, no therapy. We'll come to the details when you ask about it. But absolutely something which is very, very simple and straightforward. We do not go into very complexities of the therapies. Antivirals at times, yes, and whenever you want me, I can elaborate on the antivirals if you want me to talk about that. But those antivirals are for, again, a very small fraction of patients. Majority of them just require supportive care.
So basically, as we talk about the Omicron, it's more of a flu rather than an ARDS. So as we are expecting in other variants, we don't expect in this. So I believe the admission criteria would be same as we follow for the other diseases, like someone who has a fever and is just not responding to any of the treatment for 3-4 days, and maybe too sick or needs an IV paracetamol for that purpose. Or maybe, as you rightly said, sir, some other organ dysfunction, including the hypoxia, plays in. Then obviously we'll advise the admission. So now there have been quite a bit of, now we're still covering the OPD section. So there have been quite a been take on many. We started with the hydroxychloroquine, which has been given off. Then ivermectin came in, azithromycin came in, and now the molnupiravir. So Dr. Akshay and Dr. Rahul, I would like both to comment on this. Still, we're seeing people practicing azithromycin, ivermectin, and I don't know about the molnupiravir. So I need your comments on it. So should we be using this in OPD patients? And if yes, then at what stage, sir? Dr. Rahul, you answer this first, and then I'll take Akshay to answer.
So, Dr. Bharat, very important to understand what we should not use. Right at the beginning, you wanted to know this. I think there is now enough evidence to say that treatments like hydroxychloroquine, treatment like ivermectin have got absolutely no scientific reason that we should be prescribing them to our patients. We also know that antibiotics like doxycycline or azithromycin have not shown any supportive role. And obviously, it being a viral infection, there is no role for antibiotics as such. But there were some mechanisms for doxycycline described where people were thinking that it may be of some use. So I think we need to put these therapies back into the place where they belonged, or we should be throwing them off completely from the COVID protocol. That's no doubt about it. And that's how the national protocol has also been formulated accordingly. But there are some antiviral medications. The two predominantly available with us right now are the favipiravir and molnupiravir. Again, favipiravir is a flu medicine. which was used very, very extensively in second wave. It originally came from Japan, had a small study done by Honorable Zari Rudwadia sir in Mumbai, and following which it got introduced into the market. At that time, because we did not know a lot about it, we were using it, but trust me, again, the data for that is very, very weak, and we are not using that in this wave at all. Comes to molnupiravir, I think molnupiravir has got more problems than any good. There may be a section of patients who are elderly, that means who are above 50 or 60 years of age, who have got at least one or two comorbidities, in whom you have escalating symptoms for 2 to 3 days with absolutely no improvement in their fever profile. You may choose to give them a course of molnupiravir. That is the only place I feel we may justify to use that. Otherwise, any other population subset, it will cause more harm than any good. So I am very clear, not in the reproductive age, not in children below 18 years of age. Probably somebody who is 50 or 60 years, who's past the reproductive age and who has got significant comorbidities, chances of worsening are there, and it is not a delta variant. If you know that it is not, if it's a delta variant and if the patient is affording, maybe monoclonal antibody might be better. But molnupiravir, you've got to really think hard before you prescribe it.
Yeah, sir, I was coming to the counter question, but I'll put it later. Dr. Akshay, your comment, please. Yeah.
As Dr. Rahul has rightly said that molnupiravir, I just wanted to add, those who are diabetic, what if the studies has been done, and those who are diabetic, it won't work, and those who already had a COVID illness, the COVID infection, the molnupiravir doesn't work, and other than the reproductive system. In addition to the treatment, what I wanted to add, this doxycycline, everything is out, but sometimes suppose somebody has a persistent cough, sore throat, itchy throat is not settling down. This sometimes inhalation steroid can help. You can use budesonide around 400 milligram twice a day. So only I think other than paracetamol and inhaler steroids, that is 400 milligram microgram twice a day, other things you just keep your finger crossed and don't use it, basically, if you ask me, actually.
Yeah, correct. So what exactly
and keep the patient hydrated, actually. Whenever you see OPD patients or online consultation, ask him to drink a lot of water. If the kidney, heart is okay, ask them to keep hydrated, actually. Paracetamol and inhalation steroids in case the cough is too much, is troubling too much, because first 2 or 3 days it troubles a lot, actually.
So basically, so I have to conclude this. We are very clear in this: no role of ivermectin, azithromycin in doxycycline at all. Favipiravir was used, but evidence is very weak. So I would still say no role as far as I am concerned. Molnupiravir, I am still not very sure to be used or not. So, Dr. Rahul, I was coming to you on this counter question only. As you said, there's a set of patients that should be using it. Those are more than 50 years of age. And I'm coming to the IPT section also now. So with this question, I'll be changing my session. So why not to admit those patients and then go for remdesivir? What is your take on that? Or should we be still? No, I'm just trying to understand, sir. I mean,
I completely agree with you, Bharat. In fact, the Pine Tree trial actually has opened up a whole new subset of thing as well, which again in our country might be difficult to implement in a uniform way. But I completely agree. I think the data for molnupiravir is very, very thin, is on very thin ice. And it is better not to go on that direction. I have not initially we prescribed it. I don't think I've prescribed any molnupiravir for last 2 weeks or 3 weeks or so now. Though it forms a part of our Maharashtra government, the state task force protocol, it is coming with all these riders which I mentioned, and it is actually not a part of the ICMR protocol or the national protocol at all. So apart from the protocol, I think what you said is absolutely right. If these patients can be admitted, we can give them a short course of remdesivir, and that will be very, very good. With that Pine Tree course, which has been suggested as 3 days course of remdesivir, they may actually benefit from it. But again, the need for admission is very low, Bharat. Most of those who require admission are very clearly, distinctively requiring admission, and we should just go for remdesivir in them. We should not be thinking of giving them oral antiviral medications. And there are very few patients like that, absolutely few patients like that.
So Dr. Akshay, what's the role of inflammatory markers? I mean, question has come at the right time from the audience. What is the role of inflammatory markers in this? I mean, in first phase, second wave, we were very much dependent on the CRP, D-dimer, though I mean we very cleared it out, D-dimer is more of a marker of inflammation rather than a marker of coagulation. So as an and we were dependent on CRP even for the dosing patient with the remdesivir or the further therapy. So what is the role in this pandemic? Are you seeing the same kind of markers being high, or there's been a change?
There's some studies which show that CRP and all that, but if you ask me when and how I use the CRP D-dimer, I think it's your anticoagulation plan does not depend upon the D-dimer. That is pretty clear now in this way. Second, CRP and interleukin, what I need to say that in addition to the COVID, they also increase in the other things also. What I basically see that if the CRP is going pretty high, IL-6 is going pretty high, morning you admit the patient, morning his room air is maintaining the saturation, afternoon he desaturated, the requirement is 2 liter, 3 liter, in the night he's on NIV, in the morning he gets intubated. That point of time, if the CRP is going pretty high, IL-6 also going high, in addition to treating the number, with the number I'll see the patient is worsening, and that point of time it will help me. If patient is improving, I don't do a CRP actually, and neither modality of treatment depends only on the CRP, what I mean to say. IL-6, in addition to the COVID cytokine storm, it will increase in other things like malignancy, infection, sepsis, and all that also. So IL-6, I'll do only when I'm anticipating that CRP is going haywire, patient is deteriorating hypoxia, there is no sepsis, and then you need to take a decision to give other cytokine inhibitor. That point of time, I'll keep in mind the role of inflammatory cytokines. But regularly to do a CRP and D-dimer and depend on the plan to change according to that, it's basically I'll take it with a pinch of salt actually. That's what I mean to say.
Yeah, Dr. Rahul, your take on this. Two questions. I mean, one is the role of markers in this third way. Second is now the patient has come to IPD. When do we consider remdesivir? If yes, should we be considering yes or no? If yes, how long, sir?
Okay. So there is very little role for markers now, Bharat. We are not doing markers on the OPD level at all. So if patients are fine, asymptomatic, mildly symptomatic, absolutely no role to do any blood reports. If the fever does not subside for 2 or 3 days, or you have onset of fever which is high after 2 or 3 days, cough is continuous, then yes, a CBC and CRP. If the patient is a diabetic, I would like to do a creatinine. D-dimer and IL-6 rarely matter. Honestly, rarely matter unless I see a thrombotic. So we, in between, I mean, Paul sir is aware of that. In between a week or so, I saw acute coronary syndromes coming COVID positive for a week or so, and I just thought that whether there's a cause or effect to it. In that those patients we did D-dimer, but the D-dimers were high in those patients, and it probably just meant that they were having some thrombotic event. Was it a trigger? Possibly yes, but really no cause and effect established like that. In the subsequent weeks, the numbers automatically came down, and I think as the test positivity rate came down, the numbers came down as well. So my role for my take for biomarkers is just CRP on admission. If the patient requires clinical admission, you do a CRP on admission, you do the CBC on admission, you do a creatinine. And when would I give them remdesivir? If I'm admitting them because they are clinically worse, either because they already have a lower respiratory tract infection in terms of GGOs appearing on their X-ray or CT scan, or their oxygen saturation is dropping down, or they have a non-settling fever or symptoms which are more severe than what we could be managing at home, then I would definitely give them remdesivir 3 days course. Only patients who have got lower respiratory tract infection with hypoxia, we go for a 5-day course of remdesivir. Otherwise, a 3-day course is more than enough right now.
Yeah, sir. So I just wanted this only. So basically now we come to the IPD admissions and markers. So in this way, we haven't seen markers going up. If at all we have to do in certain patients, high risk group, we might do CRP. And D-dimer is again is a marker of inflammation more than a marker of clotting. So it's a product which comes at the end of the clotting. So any clotting, simple clotting, in the end there's a lysis and D-dimer will go up. So rather than be stroke or the MI, it will definitely go up. But again, it's a more of a marker in COVID era as an inflammation rather than a clotting. So we don't do it unless and until Dr. Rahul rightly said if we expect some thrombotic event to be coming in. And regarding the treatment, remdesivir in the IPD patient, so we expect this patient is worsening, and this is the reason why we admitted this patient. If it's just related to the COVID, not the other complication, and we should be using remdesivir. And rightly said, the new guideline article suggests it's effective for 3 days. We need not be giving it for the 5 days, except for those cases who are in ICU and have hypoxia or have the ARDS. Am I correct, sir?
Absolutely.
Yeah. So now from IPD we move to the ICU. So if someone who was in OPD we have treated, didn't do well, that patient came to IPD, and now in the IPD that patient is not doing well, and hypoxia now has landed up into the critical care. So when it comes to the critical care, so there have been very different modalities available: steroids, baricitinib, and tocilizumab. I mean, these are the one which are there in the basket as of now. So when the patient is come to the critical care area, and yes, with the hypoxia, with the ARDS, with the oxygen requirement going up, or someone was not at all hypoxic and is now started becoming an hypoxic. So when do we consider steroids or the tocilizumab or the baricitinib, sir?
So, Bharat, I think one drug which has stood the test of time during COVID, and which has been one of the most controversial drugs throughout its lifetime in ICU or outside ICU, is the steroid. And actually, steroid is the only level 1 evidence right now to be given in patients who are hypoxic. So we should be giving them low dose steroids, 6 milligrams of dexamethasone to be given. At the most, you can replace that with a 40 milligrams of methylprednisolone. So that is the only leeway in that. There is no role for high dose methylpred 250, 500 or high dose dexamethasone. The trial which did the high versus low dose steroid trial, which was 6 milligrams versus 12 milligram, also did not show any benefit in the mortality. We know that. So I think low dose steroids is the norm to be given when patients are hypoxic. I would start the steroid if I see a patient who is hypoxic on 6-minute walk test. So that's the time I would start steroid, and it works wonder because you've already demonstrated exercise-induced hypoxia in that patient. You don't have to wait for a rest-induced hypoxia at rest, because if you wait for hypoxia at rest, that means you waited a little bit longer. The patient has actually given us some time to introduce the steroids before that. Coming to tocilizumab and baricitinib, I will do a very honest confession, Bharat. I have not used baricitinib at all in even one patient since the start of the pandemic, and tocilizumab I have used only till September 2020. After that, we have just relied on low dose steroids and good ICU care. That does not mean that I am critical of tocilizumab or baricitinib. I think there is a place for it. If the patient is within first 24 to 48 hours of his clinical worsening while the patient is remitted, despite starting low dose steroids, the worsening continues. There is a rise of CRP and or IL-6, and you have been confident enough to rule out bacterial and fungal sepsis, then a single dose of tocilizumab can be given. Baricitinib, in those individuals in whom you are not able to give steroids, you would probably, so contraindication for steroid, if there is any, then remdesivir with baricitinib can be used as a combination. In those patients, it probably will work better than just remdesivir. I think this is what my simplistic understanding of ICU has been. I still feel that we standing at the end of the bed like a IV stand and looking after the patient makes a big difference rather than many of these medicines. Most of these medicines have not gone through the rigors of large randomized controlled clinical trials, as the ARDSNet protocol, for example. So if you are able to ventilate somebody with ARDSNet protocol and prone them properly, sedate them properly, the outcome is much better. What was it before this? Most of the viral illnesses, we were just giving supportive care. Apart from oseltamivir, we really didn't have anything in our armamentarium. So we should still be continuing with our ICU, good ICU care, infection control policies, and then that should be the way to actually go forward.
Dr. Akshay, you want to add something to it?
As Dr. Rahul had said, I just wanted to add, actually, steroid we won't use more than 10 days. Whatever you are using, basically it is a 6 milligram dexa or around 32 milligram or 14 of methylprednisolone or 80 to 100 milligram of hydrocortisone. Other than more than 10 days, we won't use the steroids. In addition to that, very selected few patients where CRP is more than 75 as per the recovery trial, patient is hypoxic, you are pretty sure the cause of hypoxia is only cytokine storm, we'll use the tocilizumab, not a double dose, only single dose. And whatever the baricitinib, what you ask actually is the one trial showed that in patients who receive remdesivir plus baricitinib and remdesivir plus placebo, this patient, it will little bit help in the recovery. That is the only thing. And in addition to that, whenever possible, whether the patient on NIV or HFNC, I'll see that they just lie down prone. That might help to those patients actually. Prone position as much as possible when there is hypoxic, in addition to steroid remdesivir and this interleukin inhibitor. That's all from ICU
So
treatment.
here has been a little, there have been an article. So I'll quote the article, I'll then say what we do, and then again I'll take your comment. So basically, as we clearly know, steroids, we've been using it. Those are the level 1 evidence across the globe, and obviously not for all the admitted patients. If one question came in from the from the audiences, do we use it for all the admitted patients? No, steroids are not to be used for all the admitted patients, Prasad Deshmukh. Those are to be used only when there's an hypoxia. That means when the oxygen levels in the body goes down. So either inducible or at rest, that is again debatable. But only when it goes down, then we use it, not for all the admitted patients. Uh, Recovery trial did use a TOSI, and they had a good number, around more than 1,000 patients but they use it quite early, and when the oxygen, anyone who required more than 2 liters of oxygen, they used it, and they had a good drop in the mortality. But in our setup, we start with the steroids, and most of the patient settles, but very rarely when patient doesn't settle, so the oxygen requirement goes on very fast. It goes very high, like someone who was on 2 liters or 4 liters, in next 6 hours he's on NIV, or next 6 liters he's gone on HFNC. In those cases, we run all the markers, as Dr. Rahul said it, CRP and IL-6, and we rule out the infections, and those are the cases where we consider tocilizumab. Baricitinib, yes, I have used it, but just 2 or 3 patients in the whole of the pandemic, so not much, and I really cannot comment on it. Here the variation is in the TOSI. When to use it? We use it only in certain sets when patient is being on steroids and worsening on steroids. This is where we use it. Sir, your take on this?
No, I completely agree, Bharat. I don't have anything more to add. You summed it up quite nicely. My again emphasis is that as critical care specialist, we should be relying on our time-tested ICU practices, and only those have really shown the difference. I have published my data in the Indian Journal of Critical Care Medicine with no use of tocilizumab versus use of tocilizumab, because initially 67 ventilated patients used it. There is no difference in mortality, and we had high incidence of sepsis, high incidence of using higher antibiotics, multi-drug resistant organisms in those 67 patients that I used tocilizumab. That's why I stopped using it. And trust me, my mortality has not changed. Even today, our overall ICU mortality is only 10%, 10.2, 10.3%, and our ventilator mortality is almost 22, 23%. Still, I'm sending 73, 74% patients on ventilator home. And I think I don't need to change anything, because we are using what we have learned for so many years. We are not using any experimental therapy. We are not using any magical therapy. There is no magic bullet, unfortunately, in this whole pandemic. The only magic bullet which is there is the vaccine, which is a preventive one. We don't have any therapeutic magic bullet apart from just plain simple good ICU care, hard work at the bedside. That's all.
So we just missed one modality, and then I'll come to the conclusion of exactly what we discussed. So what we missed is the monoclonal antibodies. So, what is the role, Dr. Akshay, Dr. Rahul, anyone can take this question and sum it up. What is the role of monoclonal antibody in current scenario?
Akshay, you can take it.
Antibody, by and large, it will work only in the Delta and Delta variant, because it will work against the spike protein. If you see this Omicron, the monoclonal antibody won't work. It is very less chance that the Omicron variety, this monoclonal antibody, casirivimab and imdimab will work. So other than that, basically, suppose patient comes and patient fall into the categories high risk group, diabetic, comorbidities, and you are not very sure whether to use a monoclonal antibody or not. What you can do, you can just do a specific RT-PCR test, ask them to see that yes gene depletion, and when you are pretty sure that this is a Delta or Delta variant and he fits into the criteria like age more than 61 or less than that, but diabetes, hypertension, risk factor, immunocompromise, in Delta and Delta variant only you can explore the option to use monoclonal antibody. Casirivimab was 600. But other than that, suppose you are pretty sure it is Omicron, it's very unlikely to work, because this Omicron, other unspike protein, antibody won't work in that actually. This is a take home message. And now by and large, I feel if you want to use it in first 7 days actually. Once the hypoxia develops, once the viral phase is over, it is very unlikely that the antibiotic cocktail will work. So whatever you wish to use first 7 days symptomatic RT-PCR is positive, definitely not more than day. more than 7 days or once the patient develops hypoxemia. Kidney failure, everything is not a contraindication. And by and large, when you decide to use it as early as possible, after 7 days, no. That's take home message on monoclonal antibodies.
Dr. I would like you to also take this with one question. I'll put it. Yeah, he very rightly said it has no role in Omicron and Delta as well. But we know the study which was done for the monoclonal antibodies was also in those patients who are not vaccinated. So they've done the anti-spike protein. Those who are negative, this is where the mortality was seen. So not even the Delta variant, maximum patients are vaccinated. So should we give considering in those patients or not?
Look, I think I generally don't consider it in patients who are vaccinated. I would give them a few more days to sort of see how, because you're right, Bharat and Akshay, that we can wait up to 6-7 days. So there are patients who call up and say on day 1, day 2 that I want to have monoclonal antibody, and I say just wait out for a few days, just have some supportive therapy and see how you go. Majority of them have very mild illness again post vaccination. They are not really critically ill, but if they present with the severe symptoms, if they have comorbidities, if the S gene deletion is again, or S gene target failure is again a very loose methodology now. There is a multiplex PCR kit available now in some of the labs in Mumbai, which are able to give us a bit more information about which variant we are dealing with. But they are expensive, and not everybody would be able to afford them again. So I think you have to again see that in the present scenario, monoclonal antibody has got very little role. Lesser use, the better it is.
And especially not in the vaccinated ones.
Yes.
Yeah. So I come to the conclusion on this, and then I'll come to Dr. Paul as well. So what we concluded is right or not, sir? Just let us know. So with the OPD, I will very clearly say no role of any antibiotics, including azithromycin, doxycycline, not in other way around as well. No role of ivermectin, hydroxychloroquine, what all we were using it. Absolutely no need of requiring. Just treat those patients symptomatically in adequate doses of symptomatic treatment. If at all patient needs an IPD admission, we might consider remdesivir. On OPD basis, monoparavir, we are not sure. So avoid it, shouldn't be using it unless and until, there are a few riders what Dr. Rahul said, we can take those if someone is not at all willing for the admission and not coming for the remdesivir. ICU patient steroids, yes. Tocilizumab, someone who's worsening on the steroids, not responding to the steroids, we should be using it. Baricitinib study says yes, but we have very weak experience or low experience on that. So, sir, now I would come to you and would like you to conclude and give your remarks on this, whatever we discussed. Dr. Paul, please. Sir, you are muted. Sir, you have to unmute yourself, please.
Thank you, Bharat. Yes. I'm also seeing the chat which says that there may be questions from the audience. So we should give them preference and precedence. But what you have just now summarized, Bharat, very curiously is exactly what the national treatment protocol is. So after this very wonderful discussion amongst the three very, very eminent specialists and professionals, we have come to the conclusion that the way forward is to really align treatment protocols, treatment practice along the national treatment guidelines, which the ICMR, the National Task Force, puts out. And I think the analysis that has been provided by all three of you very aptly for various areas brings out this essence very clearly based on the evidence, but also very deep practice that you all have been undertaking in your own day-to-day professional work. So essentially, what you have said is I fully endorse. We endorse the fact that there are several therapies which are now off radar: hydroxychloroquine, ivermectin, favipiravir in particular. By the way, we did not mention that also off the radar is the plasma therapy, right, which is also out of vogue. We thought it makes sense. There was the biological plausibility, but all things that demonstrate biological plausibility do not translate into clinical plausibility. And whatever translates into clinical plausibility is always having a biological plausibility as a base, but the other way around, it may or may not work. So clearly, very nicely enunciated. the principles of therapy. Fortunately, in the current surge and current pandemic cohort that we are witnessing, the treatment happens to be relatively simple, happens to be on the outpatient basis, and very often telemedicine, the word which also should be stated, through teleconsultation. And therefore, we are fortunate that this is so. We had dreadful times when we did not know how to handle this particular entity, and we did have very, very severe cases. So I essentially agree with you, and I also agree with the emphasis that you have laid on not doing harm and not overdoing. Timely and only limited use of steroids is what Akshay had highlighted. We've had dreadful situation with mucormycosis as a result of, at least partly due to the steroid overuse, and so on and so forth. So I'm with you on that. Before I stop, and we must have some time for questions, I must again compliment the fraternity of critical care specialists in our country. You are very precious. And I know that a lot of you are located in the private sector. I would like to see you more on the public sector as well. And here my request to you as leaders is that please create opportunities for DNB, DRNB training in your hospitals. You are just too few, and we realize that. We knew it, but then I think the public learned that we need many more of you. It needs a different kind of a metal and DNA to take up a tough area like critical medicine and run it over a period of your lifetime. So I urge you that you please create opportunities for formal courses, particularly through the DNB, National Board of Examination system. Because to have critical care super specialty courses in medical colleges, long gestation period, not easy, but it must happen there also. But I think the quick opportunity is that you all should have students who are undergoing training, because postgraduate training is really apprenticeship. It's only learning by doing, and you need a mentor who is correcting you all the time. And so many of you are wonderful teachers. So thank you very much for endorsing the evidence-based therapies, quick review, a global review, and a very crystal clear recommendations. I commend you, Dr. Rahul Pandit sir, and colleagues Bharat and Akshay, that you were very, very clear-cut recommendations came through. Thank you. I'll be listening to the questions of the audience.
Yeah, thank you, sir. If you allow me, I'll pass on your comments of congratulating the society in our ICCM group, and I'll give your regards to them.
And you tell them they have to create clones of you. Okay. So how do we do it very fast? No, it's a very important issue. I like Dr. Pandit to do a very simple exercise that at the current when will India have enough number of critical care specialists? And perhaps you'll be surprised that this will take 30 years, 40 years, because there are just too few and too few opportunities. So let's work for creating formal pathways which lead to degree, because only then, then it makes a difference. We need that. Of course, the general physicians and anesthetists and all can take short courses. That is also needed. I'm not saying that's, but then we also need that level so that you advance clinical medicine and clinical science. But let's now not impinge on the time of the audience.
All right, sir. Thank you. So we'll take up the audience questions. Sir, I'll take a question from Kunal Dixit. He's been asking any role of officially as a prophylaxis in national protocol of monoclonal antibodies or 2DG and any of the vitamins. Dr. Akshay.
Regarding, I'll ask first question of answer. He asked regarding the monoclonal antibody. Actually, suppose somebody is unvaccinated, some medical person is unvaccinated, or he's partially vaccinated, and that point of time, suppose he's exposed while doing some procedure like mechanical ventilation or tracheostomy, and you don't know the status of the patient who is doing that. There is only one study which showed there is a prophylactic monoclonal antibody role in this group of patients when you are pretty sure that they're exposed to Delta. Second question, this vitamin B, unless suppose there is a vitamin D deficiency, you can replace it. Vitamin C deficiency, you can replace it. But other than that, there is no role of this. Monoclonal antibody as a prophylactic, only few studies in this group of patients. Or suppose there is some family member whom you are exposed 24 hours, 48 hours without mask, or 15 minutes without mask in a closed room. That person gets Delta or Delta variant. Your status is not known, or you are unvaccinated, or uh, uh, you are exposed to that person because of some reason, allergy or all that, you are not vaccinated. Then that group of patient in gray zone, you can explore the option to use monoclonal antibodies in this group of patients.
You want to add something to it, Dr. Rahul?
Look, I more or less agree. The vitamins not to be used at all. Again, we created a whole wave of, if I may permit to be using that word, Bharat, hypervitaminosis in the first wave and second wave. I don't know whether entire human being had ever taken so many vitamins which we actually gave prescribed to the patients in the first two waves. Uh, Monoclonal antibody, Bharat, I think again this is a overhyped situation where somebody is exposed and you try and give them a prophylaxis monoclonal antibody. The only reason why I may think of would be somebody who is actually immunocompromised and has got a substantial exposure at home. And
And
we
a
know that the
non-vaccinated
person
as
who
well.
got exposed and non-vaccinated. So
Yes.
transplant patients who have autoimmune disorders, who are on methotrexate or steroids regularly or azathioprine regularly, or a chemotherapy receiving patient who received it, because their chances of deteriorating and having a severe disease are very high. That is the only subset where you may consider it. But again, cost is a big issue. Each dose is 60,000 rupees. Not everybody in the country will be able to afford that. In fact, most people, 90% above people, will not be able to afford that. So I think we should not be thinking of things which are on the fringe of the treatment modality. We should be looking at the core.
Yeah. So for monoclonal antibodies, absolutely no prophylaxis of anything apart from the vaccines. I mean, those are the preventive rather than prophylaxis. But for the monoclonal antibodies, again, I want to emphasize this: whatever the reduction in mortality is seen, or the conversion to the critical cases is being seen, or conversion to the severity is being seen, those are the cases where they really did a anti-spike protein antibodies in those, and the someone was positive. Those are patients are disregarded from the results. So it was very well studied in someone who didn't have any of the antibodies positive. So again, I emphasize, even if it's a delta proven variant, even if it's a comorbidity, but person is vaccinated, I'm not sure about the role of monoclonal antibodies. Now, what is the risk of children who may be infected? And I still don't understand. Apart from thymus, is there any robust treatment modality? So I'll frame it again. It's a question by Swati Golab. So yes, sir, you were coming on this, Dr.
I
Rahul.
think Paul sir should maybe because none of us are we are not looking after pediatric patients regularly. But Paul sir, would you like to address that question, sir?
I think let's do this in the next time. Let that be done thoroughly, because I think pediatric situations are somewhat different,
Yes,
relatively
correct.
more simple. But I'm concerned, I'll only point out one thing. I'm concerned that the children are part of the Omicron, uh, you know, chains
And
of transmission even now. And because the Omicron, surge is still going on, I'm very concerned that we should be watching out for the multi-system inflammatory, syndrome carefully. You be on a lookout. This is a time where you might be spotting some children having the
Yes.
MIS-C, as it is called. And yes, I think let's do a deep discussion on pediatric maybe next week, and have colleagues who can then cover it very well.
cover
But
it
broad
well.
principles are not very different. Broad principles are not very different. Thank you.
Sure, sir.
All right. Any word on the nasal vaccines? I mean, anyone can take this. I'm not aware of it.
I think we just wait out, because I'm sure the vaccine committee headed by Paul sir and the ministry colleagues would be looking at that. And all I have learnt in the last 24 months, and with some of the Supreme Court task force meetings, is that there is a very proactive role for vaccines in the whole government of India. And I think we should just have trust on them, and we should just wait for them to roll out the vaccine when it is safe for it to be given to people, and when it is time for it to be given to people. So it looks very promising, because the mucosal immunity will probably give us the sterilizing immunity is what is been talked about. We have to just wait for the data, Bharat. No point again in speculating. When it will come, it will be out in the open with the data.
Yeah. So one question is the last question. I'll take this again from the Nikhil. He's been asking, what about the persistent cough? So I mean, again, it's an inflammation. It's because of hyperirritable tract. So either it could be symptomatic, but it's very much persistent. Dr. Akshay covered it. We can be using inhaled budesonide. It stabilizes your tract and it resolves it pretty well. Am I correct? You can, Dr. Rahul and Dr. Akshay, you can correct me if you want.
Oh, you are correct. Absolutely, Bharat. There's one more thing which happens with that is this Omicron patients, some of them are having very bad throat pain. And that throat pain is to the extent that they're not able to swallow their food or liquids. And that requires a little bit of gargling. There are some locally soothing garglings which are available with the gargles which you can use. Warm water gargling, salt water gargling can give temporary pain relief, but does not decrease the inflammation. Some of them have settled down quite well with a one-off dose of combination of paracetamol with non-steroidal, like a combiflam or something. But that's not something which we recommend. So non-steroidal should not be taken unless and until the doctor recommends it for a very, very specific purpose.
All right. I mean, we'll take next questions next time, maybe next week. So we come to a conclusion as it's we are beyond our 8:30 time. So I thank you all, especially Dr. Paul sir. It's been honor sharing a stage with you. I'll be remembering this for my life. Dr. Rahul, thank you very much for doing this for us. And Dr. Akshay has been a brother or close friend of mine. Thank you very much. I thank you everyone for being around and passing on the clear message to the audience what is not to be done, especially in this kind of scenario. And everyone just followed the COVID appropriate protocol. Stay safe and have a trust in the system and trust in your doctors. Everything will be okay. Thank you, sir. Thanks
Bharat,
a lot.
just one word, Bharat. I
Yes, sir.
WhatsApp Paul sir, and in 2 days' time, he said, okay. Knowing how busy he is, and I know how busy he is, we all know how busy he is. I must take a bow and say that, sir, thank you very much for being here, sir. We are really honored and privileged to listen to you. Thank you very much, sir. And your kind words.
Thank you very much. All are doing great work. Thank you so
sir.
much.
Thanks a lot.
And please think of cloning yourselves
Yes, sir.
by
We'll do that.
1000x. Thank you very
We'll
much.
pass on your message for sure. Thank you, sir.
Bye-bye.
Thank you.
Thank you, sir. Bye-bye.
Thanks, Anirudh. Thanks, MD. Bye now.
Thank you, Anirudh.